So the mission of the Bloomberg American Health Initiative is to improve health and save lives in the United States, working in communities across the country, and working at the policy level, and involving direct collaboration between national and local partners, fellows, the Johns Hopkins Bloomberg School of Public Health. We are working on 5 major public health challenges, including the one that's the focus today, addiction and overdose, but in addition, environmental challenges, obesity in the food system, risks to adolescent health, and violence. There is a Bloomberg Fellowship Program, and we are counting on you all really for 2 things today. One is to make sure you follow American Health on Twitter. And then the second is that you keep in mind the fellowship program, because I heard Michelle say earlier we're going to be scaling up to 50 full scholarships for master's students and 10 for doctoral, but what she didn't say is every year. Okay, so we have a lot of full scholarships, and we're looking for people who are working now on these issues. Do not have to be in health departments. It'd be great to be in health departments, but outside of health departments, people who are in criminal justice systems, people who are community advocates. We want to be able to train people from a wide variety of backgrounds. So we hope that all of you can be mini ambassadors. If you meet people who you think would be interested in a Master's of Public Health or doctoral degree, please give them the information, connect them to us, and we have, I think you were introduced to our 3 fantastic fellows whose pictures are sort of a little bit askance on this slide, who are in the room, and they can answer questions about it too. We see this fellowship as a partnership not just with the individual, but also with their organization, because we want to strengthen organizations as well as train individuals. As I said, you can follow us on Twitter. You can listen to the American Health Podcast. How many people have heard the podcast episode on medication-assisted treatment? Yes, very good. It's a great one. We hear from Professor Saloner, psychiatrist Ken Stoller from Johns Hopkins, as well as Nicole Alexander-Scott from Rhode Island, and an individual who is taking methadone as part of her treatment. And it is really an interesting podcast. And then you can also sign up to get sort of updates on the initiative, as well as clips about our key areas. And here is our website, americanhealth.jhu.edu. So please, I hope you all are able to connect with us, people who are watching from home and people in the room. And now I'm very pleased to turn to the next segment, which is going to be a presentation of the first high-impact project that we have funded through the Bloomberg American Health Initiative. And this initiative, as it was designed with Bloomberg Philanthropies, essentially sets aside money for very innovative projects that might be difficult for other people to fund, projects that can prove or explore a really impactful point. And we started right away with tremendous leadership from the people that you're about to meet, asking the very question that was just asked: what is the best way to think about helping people protect themselves from the harms of fentanyl, given the incredible rise in death from fentanyl? And I will say that Professor Sherman, who is the lead investigator on this project, you have heard her introduced before, but I'll just say for the webcast, she is a professor in the Department of Health, Behavior, and Society here at the Johns Hopkins Bloomberg School of Public Health, and she has really devoted her career to understanding and exploring harm reduction in many different settings, not only in the United States, but all around the world. Her co-investigator is Tracy Green, who is a associate professor of emergency medicine and community health sciences at the Boston University School of Medicine and Public Health, and adjunct associate professor at the Warren Alpert School of Medicine at Brown University, and she is also a terrific leader in the area of overdose prevention and reduction. So they're going to talk to you about the forecast study.
Okay. So we are happy to talk to you today about the forecast study, which is fentanyl overdose reduction, checking, and analysis studies. Academics love their acronyms. And we could not have done this study without Ju Park, who's sitting in the back. Will you wave, please? She not only is a full-time doctoral student and a full-time analyst with me on a few projects, she tirelessly led this study and kept us all together and was really quite amazing. And also, we couldn't have done this study without Ken Morales, who is sitting up in front. have to hold your hand up. And Tricia Christensen, who worked really hard on getting all these data. It is no small thing to do a research study in 8.5 months and write a report and whatnot. So we're happy to be talking to you about this today. All right, so Chris just did such a phenomenal job of showing this slide, and we're going to focus on synthetic opioids. And you know, even hearing you talk about this, it still amazes me at that line, and it's kind of criminal. I mean, it's 2018, look how many people have died, and here we are talking about really cost-effective, simple measures, but we're glad that we're talking to you about it now. Drug checking is something that's been employed in Europe for a long time, for 30 years, both in crisis situations, so when adulterants like fentanyl came on the scene, and basic public health practice. We can often look to our European brothers and sisters for kind of common sense public health strategies that seem so radical here, like drug checking. Drug checking is something that, if you remember back, for those of you that can, to the days of the rave and when ecstasy came on the scene, I see a lot of nodding heads from people I wouldn't have expected. Drug checking happened there. There were groups called Dance Safe who were all over the country. They were groups organized by people who use drugs to literally sit at the front of raves before people were about to dance for 5, 10, 12 hours, check their pills, test them, tell them if an adulterant, fentanyl, was in it, give them water, make sure they ate bananas because potassium is leached by ecstasy, and really there to make sure. I mean, it was truly harm reduction in action. And it's amazing to me, it got press, but it wasn't quite the same as the challenges it seems that we're having to scale up this fentanyl drug testing that we're going to be talking about today. And so, you know, really this is an issue of product safety, right? People are ingesting things daily, things that they need, like we all need our coffee, because, you know, if your receptors are stimulated, if you're a heroin user, an opioid user, you need to have your heroin or opioid that day. And so, but you don't know exactly what's in your body, right? So it's kind of a crazy thing. There's no, at least here, there's no way to know what's coming into your body, and hence we have this fentanyl epidemic because we don't really, the DEA knows, but a lot of times in public health and in the day of the life of the user, there's no way of knowing what's in the pill that, or the heroin they're about to ingest, so they can make an educated decision about what they're going to do. So drug checking is a really simple way for that to happen. And we were really lucky enough in this study that we had the question about, well, you know, people were talking about these strips. There were other technologies that criminal justice law enforcement have been using for a while that are used in Europe. So can we validate these measures? So Tracy's going to talk a little bit about our aims, but and Ken is great because he does unbelievable graphics. So Ken did this. We looked at 3 cities were included in the study where we wanted to know what people who use drugs thought about the acceptability of different testing modalities. We also tested, we validated 3 testing technologies in 2 labs that Tracy will talk about, and we also interviewed service providers in key informant interviews. And we picked these cities because we are there, and also they've been greatly impacted by the overdose epidemic.
Thank you. So I'm Tracy Green. I'm happy to be here today. I'm going to talk a little bit about the study aims, but I think to reinforce the image that you just saw and those that you saw earlier from Chris, that drug use is all about geography. Every market has its nuances. Here in Baltimore, we learn of scramble. In Rhode Island, we had seen acetylfentanyl for the first time in humans in 2013. It's all about geography. And so it was very important to us to have 3 separate communities that have been heavily affected or are emerging fentanyl markets to look at and understand how drug checking could help us understand the anatomy of the supply in a way that can help us keep safe, inform people about their drug use and the contaminants in their drugs, and so they can change behavior or setting accordingly. So our study aims were threefold, and they actually were carried out in 3 separate phases. So the first phase was to compare the limit of detection and the accuracy of different fentanyl testing approaches, one being testing strips, the second a handheld machine, and the third a portable desktop machine, and that was to detect fentanyl in 210 street drug samples. The second phase, talking to people. We examined the interest in fentanyl checking among people who use drugs in those 3 cities of Baltimore, Boston, and Providence area. And the third phase involved exploring key informant attitudes on drug checking and the programmatic considerations in implementing a drug checking strategy or service. And that was important because it's a question of implementation and comfort and logistics that can really sink or swim in an approach like this. So the first phase, that drug checking technology phase. So I led this portion of the laboratory study. We looked at 3 different approaches and strategies that included the BTNX fentanyl test strips on the left side, Raman spectroscopy in the form of a TrueNarc made by Thermo Fisher, and an FTIR machine, or an infrared technology-based machine made by Bruker Alpha. And so those 3 are the instruments that we tried out in the lab. We were very happy to collaborate with the Baltimore Police Department's Forensic Crime Lab just around the corner from here. I got to drive by and wave by the taxi. And the second site, the Rhode Island State Department of the State Public Health Department's lab and the Drug Chemistry Unit. And in each of these, in both of these labs, we brought a protocol and a clarification of how to use these instruments. And the training for the instrument manufacturers was actually provided directly from those manufacturers for our lab staff. And they were able to donate those machines for the use of our study, which was wonderful. The strip training was based on the package insert, and also by connecting with harm reduction organizations around the country that are already using this strip, so we learned from them, the experts. So our 2 studies, and I'll just briefly overview the methods. The first for the limit of detection. This is sort of a how low can it go? Where do we stop seeing fentanyl in these technologies? And to do this, we bought fentanyl standard. I did not myself, but the labs purchased the fentanyl online from a DEA certified vendor and obtained that fentanyl standard and prepared solutions either in ethanol for the TrueNarc or in water for the strips, because the strips are designed to detect fentanyl in urine, and we are mostly water. So we use water for this case. And in sequentially testing samples of lower and lower concentrations of fentanyl, we can see, using serial dilution, we can see sort of where it is no longer detected in the sample. The second approach for the testing then asked the question about accuracy. So we were able to capture the sensitivity and specificity in real street samples. And this, I have to give a big shout out to Baltimore City's police department, once again, and the Providence Police Department, who were able to provide us 210 samples of powders and pills that were obtained from street drug samples. So exhibits from the community to mimic actual street drug quantities and purity levels. And those cases were sampled randomly sampled by myself and by an intern at the police department in Baltimore. Half of them had fentanyl confirmed already by GCMS, by the forensic chemistry lab already, and half were fentanyl negative. They may have been cocaine only or a heroin only, or maybe not even an active drug. The lab staff who then carried out this portion of the test were blinded, so they did not know if it was fentanyl or positive or negative. All they knew was that it was a powder in a test tube, and they were using these 3 instruments to test to see whether it told them that it was positive or not. And we used a protocol to make sure that both of the labs were moving forward in unison. So what did we find? As you can see, the 3 technologies are on the left-hand side. The detection limit, and this may be less meaningful or more meaningful if you are chemistry-oriented and lab-oriented, but you can see that the detection limit is lowest for the BTNX fentanyl testing strips at 0.13 micrograms per ml. The Raman spectroscopy, the TrueNarc, 25 micrograms per ml, and the Bruker Alpha, we were testing powder, so in this case we didn't create a solution, but we could see that per percent weight, a small proportion of 3 to 4% weight of the powder if fentanyl were in there, it would be able to detect it. Now moving to the actual street samples, what did we learn? So the sensitivity and specificity are reported here for both the Rhode Island lab and the Baltimore lab. As you can see, the sensitivity, or the ability to find fentanyl if it is in there, truly in there, for the BTNS test strips was 96% in Rhode Island and 100% in Baltimore. For the TrueNarc, it was 61% in Rhode Island and 39% in Baltimore. And the Bruker Alpha was tested only in Rhode Island, and those scans reflected 83% sensitivity. For specificity, or being able to confirm that it was not in there, fentanyl was not in the sample, The Rhode Island lab for the testing strips found 90% specificity, and the Baltimore lab 98% specificity for the fentanyl testing strips. For the TruNarc, there's a two-step process, one where you take the machine and point and shoot to the product or the specimen, and another where you take a small scoop of it out and place it in ethanol and then wait for it to dry and test that. That's a two-step, so we present both here for the specificity. So in a point and shoot mode where you don't touch the sample at all, we had 100% specificity in the Rhode Island lab and 98% in the Baltimore lab, and 92% overall when you use the scoop approach. For the Bruker, it was 90% specificity. So importantly, I think in terms of thinking about false positives and false negatives, they are minimized. Each of these instruments have considerations, and you can see that they are minimized or especially in the fentanyl testing strips, but important considerations. We were also very lucky to have 4 additional samples that were fentanyl analogs, either alone or in combination with another drug like cocaine or heroin. We were able to find acetylfentanyl and furanylfentanyl with the testing strips 100% of the time. However, it did only test as fentanyl. It did not tell us that it was acetylfentanyl or furanylfentanyl. It came back as positive for fentanyl. And for the Bruker Alpha and the TruNarc, the 2 machines, it detected fentanyl in 3 of those 4 analogs. But some important instrument considerations and why this study is about drug checking, not specifically about drugs, the fentanyl strips, but more generally about instrument considerations, because each of these instruments we tested have a contribution to make to the conversation about drug checking. The first they'll begin with is the fentanyl testing strips. See, these act very fast, between 3 and 5 minutes to a response of whether fentanyl is present or absent. There's very minimal training associated with the use of this tool. Easy to use. The cost is relatively low at around $1 a strip. However, that cost can also add up if you consider that people may actually test multiple times a day or multiple times a batch, and so forth. So it's an important consideration. It does, as I just mentioned, only test fentanyl, and it cannot distinguish between those analogs. And we should really be thoughtful about, this is one of the test strips itself here, guarding against confusion in understanding and reading the results. 2 lines or 1 line, what is negative and what is positive. And those low fentanyl concentrations, because fentanyl, for instance, in really potent analogs like a carfentanil, may be even lower than the detection that we've been, even though this was a very low sensitivity and very small limit of detection, we may still be seeing fentanyls and analogs circulating that are even lower. For the TruNarc, some important considerations. It also returns a result in a fast turnaround between seconds and up to 4 minutes. Some training is required in terms of understanding and working with the machine, but it is essentially easy to use and incredibly durable. It is, of the 3 that we worked with, it's probably the one that you could even drop on the floor and it'd probably be okay. It's designed for use in law enforcement and field investigations. So for that matter, you could see its potential in a syringe service program, for instance, or other place where it may be used on a van or very durable. It is challenging, however, for street samples that are of low purity and mixtures of multiple fentanyl analogs and so forth. So that 2-step testing process, which is meant to help us see fentanyl and heroin, is really a necessary component. It is ideally suited for high purity samples, such as what we would see in a narcotics investigation. The unit is designed for use in law enforcement, and for that matter, we did see that if you saw a brick of something, you'd definitely be able to see it with much more clarity than if you saw it in a street sample that had been cut multiple times over with very small quantities of fentanyl. But in this instrument, what's interesting is that the scans that emerge from applying this tool to a sample creates additional analysis and additional material that could be used in and exported for public health surveillance, for instance. And that has a lot of potential. For the Bruker Alpha, probably the fastest of the things that we tested, 30 to 60 seconds for a scan. It is easy to use and little training is required to do the scan itself. More training is necessary to interpret the results, and far more training would be necessary to curate the scans and understand, maybe create a library of, for instance, of local scans. What does furanylfentanyl look like in Baltimore? What does acetylfentanyl look like in Rhode Island? You could create that kind of library with these scans, but it would require a little bit more training to do so. It is perhaps superb for street samples because it is designed to do mixture analysis and component analysis. So you can see 65% of the sample is a cutting agent, and 35% is this, and less than 1% may be fentanyl. And in this case, the utility of it, though, is a function of how much training you can provide to the person who is operating the machine and the people who are communicating results, and the potential to construct and curate local libraries makes these two machines in particular very attractive to a drug checking approach, for instance, for public health surveillance, or for creating a fuller and more complete picture of the drug supply. So in these ways, the TrueNarc and the Bruker Alpha can tell you if cocaine is in that substance, for instance, but a strip could also very definitively tell you much more definitively than the instruments that there is fentanyl in it as well. I'm going to switch to phase 2. Thank you.
Thank you. So that is Tricia doing a mock interview. Although she did the interview. So now we're going to talk about the surveys that we conducted with people who use drugs in Baltimore, Boston, and Providence. And, you know, these cities are obviously very different demographically, and you'll see some of those differences. We also recruited people into the study differently. So we in Baltimore, we have a mobile van. Sean Allen, who's sitting in the back, actually created these maps of hotspots. We used heroin and opioid arrest data as well as 911 calls to find the places that were the best to recruit people to in this study that kind of had the highest concentration of, as indicated by those measures. And then Tracy worked with some wonderful harm reduction organizations in Boston and Providence and recruited through needle exchange programs there. So just to show you who were in our study, there are some similarities, but there are a lot of differences. Majority men, although I was surprised in Baltimore, usually in samples of, besides the female sex worker studies I do, usually samples of people who use drugs in Baltimore, it's like always 70% men. Because we had a range of routes of administration, which you'll see, we did not just interview people who inject drugs, we also interviewed people who snorted or smoked. We had a broader range, we think, of gender distribution. The age was relatively similar at an average age of 43 years old, but you can see the demographic, the racial composition was different, that there were many higher percentage of whites in Boston and Providence, as you would expect, in African Americans here, and more Hispanics in Boston and Providence. Homelessness was incredibly high among all three cities, and I mean Boston just exceedingly high, which goes to show that the harm reduction organizations are actually reaching some of the kind of highest risk and most vulnerable populations. And then high levels of arrest, which are kind of characteristics of, unfortunately, of lots of drug-using populations. So we asked people about their, we asked complicated questions about drug use patterns in the past 6 months and ever, and we're interested in how people started, like Chris talked about kind of that, because we think trends are changing over time about what drugs people start with. But as you can see, just high rates of polydrug use. And something that was really surprising to us, speedball, for those who don't know, that's a mixture of heroin and cocaine. It's common in Baltimore for people who inject drugs. So likely that percentage is lower because we had people who did not inject drugs in the sample. A lot of people suspected that fentanyl was in, and there were significant differences between the three sites, but there was a high level of suspected fentanyl use. High rates of overdose, again, Boston, the highest. And then, it's kind of unbelievable. This just sticks with me. I've never asked this question. How many people have seen someone die ever in their life from using drugs, presumably with them? I mean, that is just trauma in a line, and something that, I hope that we talk about more today. I know in some of our breakouts we will, but, the trauma of what's going on now, it's not just in the charts and graphs, but it's in the lived experiences of people who are traumatized by some police, who are traumatized by lots of things in their life. But witnessing a death is just, fairly traumatic, something I've not done. So I think that's an important thing to understand and to explore the impact of that. Okay, so to the issue of fentanyl, we were really happy to see that people were interested in fentanyl checking. 86% of people were interested in fentanyl checking. And then, of course, people are concerned about using drugs with fentanyl in it because of all the press kind of PR and the website around this. Tracy and I talked to a lot of reporters yesterday, and a handful of the people that I spoke to were kind of totally taken aback when I would say it's not like people who use drugs wake up wanting to die more than anyone else. And that shouldn't be shocking, but I think that people are shocked by that. Hopefully no one in this room is shocked by that. So of course people are concerned, and people felt like that fentanyl checking would actually protect them from experiencing an overdose. So, and we asked a number of other questions about fentanyl use. Some more I'm gonna show you today. Also, the question often comes up, well, aren't people seeking fentanyl, which is part of this myth. Everyone, a lot of people want to die. And most people weren't preferring to have fentanyl in their drugs. If you talk to people who use drugs, it's a different high. There are people that I've talked to recently who said they actually quit drug use in Baltimore because there was so much fentanyl and they were scared and they didn't really like the way that the drug feels. It's a different rush to your head. It lasts a shorter amount of time, et cetera. It also depends, as Tracy talked about, what else is in the drugs that people are using. So, and of course, yesterday, one of the reporters asked, well, what about those 25%? I'm like, no, I want to focus on the 75%. And we are exploring who are those 25% that actually seek it. We have a hypothesis it might be some younger people who actually have mostly used heroin with fentanyl, so they don't know that's the high that they're used to, but that's something that we're going to explore. All right, so 70% of people, just more about fentanyl checking, because that was kind of the aim of the study, reported that knowing their drugs contain fentanyl would actually help them modify their usage or to employ harm reduction without having testing strips there. So they would avoid purchasing drugs. They would use your drugs more slowly. They would do a tester shot. That's when you taste the drugs. They might use less than they had originally intended. They may throw away the drugs instead of using them. That wasn't, most people. And they may actually tell people, look, that person is selling fentanyl. And then, of course, we were interested, like Tracy said, where will checking take place? Where do you want drug checking to take place? So syringe services programs were the highest percentage, other health clinics, drug treatment programs, other nonprofits, safe consumption spaces, and homeless shelters. So it was, a broader range, and it's important to, I like the snaps for the safe consumption spaces. It's important for people to realize that people go to lots of different places. It's important to know where people interact with systems and where this can be useful. It's not just at a syringe exchange program. There are plenty of people in Baltimore City who use drugs who particularly don't go to a syringe exchange program because they're not injectors, or they may not, they were not people who inject, or they may not, for whatever reason, go to the exchange program. All right, so we also had some open questions in our survey, and so I'm going to show you a few quotes from participants. Where does this need to happen? There's been a lot of research. Sean has done studies in DC looking how far people travel to go to syringe services programs. We know from work with women engaged in sex work how far people travel, and people want things in their neighborhood. We all want things in our neighborhood. I was happy when Whole Foods moved to my neighborhood. So it's really important to know where drugs are used in the community and to make sure that it's accessible to people. And this is another picture of Baltimore. Anything I put in me, I definitely want to know what's in it. I'm married to it, and I don't want to leave my wife. They're dropping like flies off this stuff. It's really important, we felt, to kind of get the words and also some of the stats that we've collected about what people do to protect themselves, because, of course, they're the experts dealing with this every day. All right, so we wanted to look at what were correlates in a multivariate model of people's interest in drug checking. This is preliminary analysis, but what we found is people that were older, people that were female, people that were African American or Hispanic, and multiracial, so basically everyone but whites. People who had witnessed a fatal overdose and also used the drugs they thought they had fentanyl. So that would make sense that those are folks that are interested. And those were all significantly associated with drug checking. So now we're going to talk a little bit about the stakeholder interviews that we did. We did 32 key informant interviews. Some of the interviewees are in the room. Someone's quote is up here that is one of my favorite quotes. And we really thought it was important. We talked to people at a range of not just service providers. We included some really powerful advocates like peer and family groups. So there's some amazing parents of people who have died of an overdose who Whenever I'm in Annapolis, they show up, they advocated for Good Samaritan laws, they advocated for expansion of syringe services programs. So these are people we want on our side and wanted to know what they thought about this, because I will say that at least in Annapolis, they listen to moms and dads more than they listen to my sitting up there talking about data. So we wanted to include them in our sample. So just to say quickly, obviously there were a lot of quotes, but people were definitely interested in exploring the concept of how they could provide drug checking in their organizations. And I'm really struck by this quote that, you know, it's not just about letting someone know what's in their drugs. It's also about giving people the choice to make an informed decision. And you can't underestimate the power of that, and giving people some control and engaging in a dialogue. It's not like you're just gonna throw these strips out. People are gonna hopefully engage in harm reduction counseling and talk to people, have a minute to talk about, just like with syringe exchange, which there are a lot of parallels to this kind of in the early days, to talk about how they're doing, what's going on with their lives. Things of that nature that get people engaged in services. And one of the reasons we wanted to talk to service providers is that there are other services there. If people do drug checking, they might take advantage of other services that are present as well. So Tracy's going to end with some of our key recommendations.
Great. So sort of saw those three phases. Are there instruments out there that we could even imagine using for drug checking? The answer is yes. Second phase, would people who use drugs even use a drug checking service? Do they see value in it? Are they interested in understanding what's inside the drugs that they might be consuming? That answer is yes. And the third phase of, are there service provider considerations and other key things that we need to think about for implementing something like this? And the answer is yes, there are. And so we hope that that you can hear some additional thoughts and see those answers in these key recommendations. So the first recommendation, bringing it together, is that public health and harm reduction agencies should address logistical questions and implement anonymous drug checking as part of a public health strategy to save lives from fentanyl. Second recommendation is, as you heard from Susan, that harm reduction counseling, health education, and connection to services, including treatment for substance use disorder, should be part of any drug checking program. And that's a natural extension of many of the tools we already offer in our harm reduction environments. And the third, fourth, and fifth recommendations are here. The third one being a signal to research, philanthropic, syringe service, and overdose prevention agencies to really support pilot programs that are seeking to test, evaluate, and scale up drug checking services as part of a comprehensive approach to addressing the opioid and overdose epidemic. The fourth is to encourage entities in the private sector to continue to develop mobile technologies for effective drug checking. You saw that there are a couple really good ones out there, alone or in combination, could help us get more information into the hands of people who implement services, people who are using these drugs, and bring back surveillance of the drug supply and local trends that can help us be more responsive in real time. The fifth and final recommendation is a reflection to our state and governmental agency partners that public health surveillance can do more, and that they should include information about local trends in the drug supply, such as those that are available through drug checking to inform timely and accurate responses. As many of you know, we have forensic information laboratories providing excellent data, and I don't want the DEA or any of the NIFLS data sets to be changing and stopping it at any time, but they tell us about controlled substances only in singularity, not in combination, and certainly not the contaminants that may be causing a lot of the adverse events in the populations we're serving and caring about. That's a public health approach that's more comprehensive about the supply, about the people consuming, and about the communities who are being affected. So those are our 5 recommendations coming forth from here. The acknowledgements are long. I will give enormous shout outs to the Boston and Rhode Island crew, especially to Michelle McKenzie, Kim, Aubrey, Katie Clark, Eric, Joe, and Shanker, and the folks in the labs who helped make this all happen, and Sarah Mack and Eddie Hope.